Hello, everyone. I think we can go ahead and get started. Welcome to Security Health Plan Academy. A couple of notes here before we move on. I ask that if anyone has any questions throughout the presentation, go ahead and type those into the chat feature here in Zoom, and we will present those to our presenter after her presentation and try to get all of those questions answered. We will send everyone here today a follow-up email later this month with a link to a recording of today's webinar, as well as the list of all of the questions anyone had during the webinar today or anything that was emailed in advance, as well as some helpful links about today's topic. So without further ado, I'd like to introduce Marshfield Clinic Health System pulmonary medicine nurse practitioner, Jackie Pfeifer. Jackie has worked as a pulmonary nurse practitioner for over 10 years. She has a special interest in COPD and COPD management, and she hopes to help her patients improve the quality of life and help decrease the burden of symptoms through her work with COPD management. So Jackie, thank you for joining us today, and I'll turn it over to you.
Great, thank you. Hopefully everybody can see my screen and can hear me okay. And so what we're going to talk about today is just really the basics about COPD and hopefully answer some of the questions that you have. So the title is COPD when the breathing gets tough. For the objectives, we're going to discuss symptoms and diagnosis of COPD, discuss any medications and treatments for COPD, discuss the management and flare symptoms that you may have when your breathing gets worse and the triggers that may cause that. Also some lifestyle management and how the disease progresses over time. This is a picture of myself, and again, I have been working for over 10 years. I have a COPD clinic that is holistic, and we try to manage all of the symptoms that people have because COPD really affects the entire body. It affects the lungs, the heart, skin, the brain, the gastrointestinal tract, your mobility, even some of your mental health. And so what we try to do is really identify things that we can fix and modify and really make sure that you have the best quality of life, because that's what we're looking for with this. So a basic definition of what is COPD, it's an acronym, and what it stands for is chronic obstructive pulmonary disease. It means there's a change in the airflow of the lungs. COPD, you might have heard asthma or emphysema or chronic bronchitis. Those are kind of all umbrella terms that COPD is categorized under. So they're just a little bit more specific based on if you have emphysema or chronic bronchitis, but we're still all talking COPD. And the best way that I can describe this is I'll either use the analogy, if you can think of your lungs like a tree and there's a branch and it kind of keeps branching out, all of those little airways get smaller and smaller, and that affects how the air is able to get in and out of the lungs. The only way we actually know for sure if you have COPD is if we do spirometry testing in the office. And most COPD patients should have had this done at some point. There's some numbers that we have to get to order to say, yes, you have COPD or no, you do not. A lot of people will be told, well, I was a smoker for my entire life, I have COPD, and that's not necessarily true. So if you think you have COPD, it's really important to get that testing done so that we know the severity and how much lung function you have left or can we improve upon. Yesterday was World COPD Day. Today is National Smokeout Day. But COPD affects about 16 million patients and family in the US. And the reason why I included families in this is because it doesn't happen in isolation. There's a lot of families that also have to deal with the effects of their partners, their kids, their parents having COPD. And so we really need to include those in the dynamics as well. COPD is the sixth leading cause of death in the US in 2020. It actually fell a little bit in 2020, but worldwide it's actually third leading cause of death. And about a quarter of the patients of that 16 million have no idea they have COPD. And what we're really looking for is early diagnosis, early management in order to prevent progression of disease. So I pulled this map from the CDC a few days ago. It's a little blurry, But what you can tell is the dark blue is the higher prevalence of COPD. The lighter the color of the blue, the less prevalence of COPD. And a couple of in Wisconsin, I believe this is Adams County right here in the darker blue, and that might be Brown County up in there, maybe Menominee County. I'm not quite sure which one that is, but in Wisconsin, it's a moderate burden. It's about 4% of the population. But what I want to point out here is if you look, in this region here, there's a higher incidence of COPD, and what they may call this is the iron belt, the rust belt, but it's also the tobacco belt. And not surprisingly, they have some of the highest incidence of COPD in the entire US. I think the highest was West Virginia at 11% of their population has COPD. So just a little fun facts. So I spoke a little bit about this, diseases that are associated with COPD: emphysema, chronic bronchitis, asthma, chronic respiratory failure. And what that means is you may need oxygen, or you may just not get rid of the carbon dioxide as easily as you would if you didn't have any lung disease. You may even not be on oxygen. You may just be having a BiPAP at night or CPAP at night, something of that sort. Bronchiectasis is a disease where people have mucus and they're creating mucus constantly, and their airways are filled and they don't realize that they have a cough until they start moving around or changing position. It's associated with COPD as well. And I put lung cancer, not directly associated with COPD, but the smoking risk is also there. So it's pretty common for some of my patients with COPD also have lung cancer or lung cancer risk. And that's when we start talking about doing low-dose lung cancer screening studies to try to identify those patients that are at risk earlier rather than later. But you may, like I said, have seen or have been told, oh, I have asthma or chronic bronchitis or emphysema, and we're still kind of talking about COPD in that respect. Okay, so how did I get COPD? And there is a guideline that comes out every year. It's by the Gold Association. So if you're looking at wanting to see where we come up with all these strategies and these recommendations, it was 204 pages when it came out on Monday. And it talks about how all these treatments occur and how people get COPD, but they're starting to identify more that you can get COPD more from smoking. Now, smoking is the #1 reason that people get COPD, but you can also get it from recurrent respiratory infections. If you were a child or if you had a really bad pneumonia, that might have caused some issues as well sometime in your life. Asthma, and I'll kind of spin this in occupational exposures, but in asthma, you can have very severe asthma, and if it's not well controlled, then theoretically it might turn into a part of COPD later on in life. And so you can have asthma and COPD combined with the two. It used to be you just had asthma or you just had COPD, and now we're really identifying you can have both ends of the spectrum, and somewhere your disease is kind of meeting in the middle. Occupational exposures, so things like if we bring back to West Virginia, coal mining, but in our area, farming is a big example. And farming has a lot of exposure to inorganic and organic material. It's dusty, it's moldy. And so when you're inhaling that stuff, you can cause some damage to your airways. And farmers are pretty hardworking people, and usually a little cough isn't going to bother them, but that cough over time may cause some worsening breathing problems. Genetics is one. There is a disease called alpha-1 antitrypsin. We typically recommend anybody who has a diagnosis of COPD to get tested for alpha-1 antitrypsin. And what it is it's a enzyme that is not produced in the airways to help kind of lubricate the lungs and make them move so that they're not stiff and cause emphysema later in life. About 5% of the population has alpha-1, and you can get it through, if you have a carrier and your spouse is a carrier and you have kids, that's how people can develop this disease. fairly common in Norwegian and Scandinavian population. But it's still fairly rare, but it is around in our area as well. And then environment. And so when I'm screening patients, I'm asking where they're living, do they have any burning of wood? Some of the worldwide components of COPD has to come with people burning what they call biomass fuels, which is wood or garbage or anything for a source of heat that's putting off fumes into the air that can cause COPD. There's just a number of things, but all of these factors, and you may have one, you may have all of them, can contribute to how you got COPD and really what the severity is. So common symptoms of COPD, and you could have one, all of these, or you might not even have any of them. But the first one is cough, and it's either dry cough or a productive cough. Most people with COPD that have a cough will say, I cough first thing in the morning. Once I cough that up, I'm fine for the rest of the day. Or it may just be a dry, irritated cough that they have every now and then. Shortness of breath is typically with exertion or strenuous activities. So things like lifting, pushing, pulling, carrying anything of weight for any sort of distance will cause shortness of breath. Usually it's not shortness of breath at rest, but you may have some of those symptoms. And so that's kind of why I'm asking, well, tell me more about your shortness of breath and what's bothering you the most. Wheezing, sometimes people hear themselves wheeze, sometimes they don't. Wheezing often happens also with activity, and it's just a high-pitched squeak noise that people may hear, or their family may say, you're wheezing. And that may be where they started with an albuterol inhaler or something to help relieve that. If you have frequent respiratory infections, then we should be looking at, do you have some sort of airway disease? Is it asthma? Is it COPD? Is there something else going on? But that should be a clue that something's not quite right in your pulmonary system. Sensation of chest heaviness and tightness. So about, I think it's maybe 13, 14 years ago, Spiriva first came out, and that was where they had the elephant sitting on the chest and it's so heavy, and then everything got better once they took a medicine. And that's what a lot of times people will describe as a very heaviness in their chests, like they just feel like they can't get enough air. I'll ask about nighttime symptoms. Are you coughing or wheezing or choking or waking up very short of breath? And sometimes when you have component of breathing issues, you might feel that at night as well. If you're in the hospital, I'm definitely going to be looking at what's bringing you in the hospital and what's causing these frequent exacerbations and needing these, a lot of times, prednisone. So if you're on prednisone a lot, we need to be figuring out, do you have COPD? What else is going on? Because we want to minimize that exposure to prednisone. So those are just the general kind of common symptoms you have. And like I said, you may have something entirely different than that, that's your trigger, but these are the most common and typical ones you might see. And so these should be kind of a red flag saying, oh yeah, I have that. Or when the weather changes, I can feel it in my chest. And I will tell my patients, everybody's a better weatherman than the weatherman himself, because most COPD patients can feel that barometric change, and it comes with chest tightness or shortness of breath. So just a little bit of lung anatomy to kind of get you back to where we're talking about as we go through some of this disease progression. So what you see here, this is your trachea, and the trachea separates off into the bronchus and the bronchi. And again, if I bring back that analogy of a tree, it looks like a tree kind of upside down with all the branches going out. And as you get farther and farther out, these airways get smaller and smaller. That's how a normal lung looks. You have 3 lobes on the right side, and this is right because it's a mirror image for us. So this is right upper, right middle, right lower. And on the left side, you have left upper, left lower, and right in this space right here would be where your heart is. And that's why you don't have a 3rd lobe on that side. At the end of all these little branches that kind of come off here, on the right side picture, you'll see a enlarged picture of what those end of airways look like. And you can see there's all these little grape-like sac clusters. Those are your alveoli. And the alveoli play an important role in your body because when you inhale, it goes in through your nose, down through your airways, out, and then it gets into these little grape-like clusters. And that's actually what, by diffusion, it's a process where the oxygen gets moved into the bloodstream, and that's when they check your pulse ox and they say, oh, your oxygen level is 98%. So this is an important way of knowing how that oxygen is getting in there. And these little purple strands right here, those are muscles that are wrapped around the airways, that sometimes people feel that chest heaviness. That's where these airways are, the muscles are getting tight. And this is just a cross section of a diameter of an airway, and you can see there's muscles around it, and the airway is nice and pink, and there's no mucus in there, and that's exactly how this should look like. So this is normal lung. So in emphysema, people will often say, I can get air in, I can't get air pushed back out. And then back on those little grape-like structures, if the right side is a normal one, it's got little compartments and every hand has a little chamber that's normal. On the left side, it kind of looks like Swiss cheese. And when I explain sometimes on a CAT scan of your chest, if you've ever had one, you can see that, quote, Swiss cheese look on a CT where it's all of these damaged alveoli that are causing problems. And so you're not getting the air and ventilating and getting that carbon dioxide pushed back out the way you should. Sometimes you get a little swelling of the airways, and the airways also become narrow. And I usually explain emphysema like an overstuffed closet that you've shoved everything in there for your entire life and you've never wanted to look at it again. There's just so much stuff packed in there. There's just not enough room for everything to kind of move around. And versus a normal lung, the airways are nice and open, and all the little air sacs are doing what they're supposed to do. Chronic bronchitis may also be referred to as a smoker's cough. That is the person who they're just constantly coughing, like all of the time, constantly creating phlegm. The definition of chronic bronchitis is a chronic daily cough over 3 months for a 2-year period. But it's just mucus upon mucus upon mucus, and there's just no ending it. And sometimes patients, they just rattle, their loved ones can hear them rattle. But on a normal airway, you can see it's nice and clear. And in chronic bronchitis, you can see this tube is very irritated. There's mucus in there. It's very swollen. And so because of all of that swelling, they're not able to move that mucus through their air cavity the way they're supposed to be actually able to cough it out. Smoking also contributes to this because there's little hair fibers in your airway that are supposed to move that mucus up. And when you smoke, you burn off those little air fibers. And so that mucus just stays in the chest and it just rattles constantly. Okay, so we're going to spend a little bit of time talking about the medications and treatments. This is not an all-inclusive list, particularly when we're getting to inhalers. This is really an overview. Your medications may be different than what's on this list, but I'm just kind of giving a general guideline for the treatment of COPD. So for COPD, in the last, I'd say 6-7 years, there's been at least 6 to 7 new inhalers, which is amazing. There's been some generics, which I never thought would happen. But inhalers are the backbone of COPD care. It's about all we can do for COPD for the most part. And there's 2 types. One is a rescue and one is a maintenance. And when I say maintenance, I'm very specific in that word because a maintenance is like maintenance. You do anything else for yourself. You do it for your car to keep your car running. If you don't do that maintenance, then things are going to become stressed out and it's not going to work as well. So I'm going to use those 2 terms, rescue and maintenance, throughout the rest of the talk. Steroids, everybody loves prednisone, dexamethasone. They go in the hospital, they get some steroids, they feel fantastic. They come home, they're like, what happened? I don't feel as good. And so steroids are a hormone. It makes you feel better by taking away the inflammation, but it also causes a lot of long-term side effects, particularly the oral steroids. So if I were to leave you on prednisone every day for the rest of your life, I might make you diabetic. I might make you have high blood pressure. I could cause bone loss. I could cause a bone fracture in legs, arms, spine, vision changes, skin changes, weight gain. It's a great drug short term, terrible drug long term. It's not anything we want to stay on. For periods of flares, there's antibiotics. Some patients may get put on chronic antibiotics to kind of decrease the amount of phlegm and mucus that they're creating. We've got oxygen. We want to make sure we're treating underlying conditions such as sleep apnea, heart failure, cardiac disease, exercise, and really prevention, making sure that we're preventing any further deterioration. This is a list of all of the current medications on there. Not all of them are for COPD. Some of them are for asthma, particularly the biologics and the bronchial thermoplasty. But this is the best image I have for all of the inhalers out there. So how do we pick an inhaler? We do the breathing test, so I know how severe your lung disease is. It mild, moderate, severe? Do you have any response to the albuterol? Do I need to give you a steroid? What kind of complaints are you having? Are you wheezing, tight in the chest, coughing? How many flares do you have? Also, when I'm looking at an inhaler, I want to know what kind of side effects. Is it going to interact with any of your medications? Are you going to be able to use the device correctly? Finally, what is insurance going to cover? And that makes a huge difference, because just because you see it advertised on TV, I'm going to tell you, probably means it's pretty expensive to cover. And so there's lots of other great medicines out there that may not be the latest and greatest, but there's other things that will work as well. And so we try to balance between insurance and which medicine's the best one for you. And like I said, we have to take all of that into account. The rescue inhaler. This is just a picture of some of the rescue inhalers. You may have one that's a different color, but albuterol is albuterol is albuterol. It does not matter which one you have. Most people like this Ventolin because it has a different propellant behind it. It just makes you feel like you get the medicine, but it does not make any difference in terms of medication itself. And so they all work exactly the same. They only work within the first 5 to 15 minutes. They don't last very long, which is why you have to keep using it. We really want to make sure you're not overusing it because it's associated with increased risks. But you can use it for wheezing, coughing, shortness of breath. And again, I put on there, it's intended for quick relief. I often tell people, if you can walk a distance and stop and recover and keep on going, you might not have needed your albuterol, but people like to do something. So they'll take a puff of their albuterol and keep on walking, and you may or may not have needed it. So it just takes a little self-reflection. This one is Combivent. It's also a rescue inhaler. It has albuterol and ipratropium in it. And what it does is it relaxes these purple muscles around the airways, so relieves that chest heaviness. Does not require use of a spacer, as some of the others do. The ICS, which is inhaled corticosteroid or long-acting beta agonist, they help control inflammation and keep airways open for over 12 hours, usually a twice-a-day dose. If the medication is written as twice a day and you only take it once a day, you're only getting half of the medication. And so you really need to take it as prescribed or as you've been told to. It's not a rescue medication in most cases. So, if you take, I'll just use Advair. If you take Advair twice a day and you want to say, oh, it's a bad day, I'm going to take an extra dose, don't do that. Okay. It's not meant to do extra. You'll run out early. You'll have side effects. You just want to make sure you're taking this. So this is kind of your base. This is where you're starting your treatment. And then the albuterol may be where you're adding it in if you're having a bad day or more symptoms. But this is Symbicort, Advair, Dulera, Breo. They're all the same. It's just patient dependent and insurance dependent on which one's going to work best for you. Long-acting anticholinergic is a LAMA. It relaxes that purple muscle around the airways I showed you before. So like the Combivent's only lasting 4 to 6 hours. This one's going to last 12 to 24 hours. Again, not a rescue medication. So the Tadorza, Spiriva, and the Incruz all work as maintenance inhalers. Stiolto and oral Bevespi work by relaxing the muscles of the airway and decreasing some inflammation, but they do not contain any prednisone steroid in the inhaler themselves. If we can get by without having a steroid in the inhaler, that's really what we want, but some people need it, some people don't. We want to make sure your symptoms are controlled as best as possible, and these are also some options as well. And Stiolto and Anoro are once a day, Bevespi is twice a day. Triple therapy. So you can get triple therapy by combining a couple of inhalers, whether you're on Advair and Spiriva, or doing an all-in-one inhaler like Trelegy Ellipta or Breztri. These are the only two in the category right now. They have a steroid, a long-acting albuterol, and a medication to help open up the airways as well. Very expensive, very, very expensive right now. So if you happen to fall in the donut hole or have a deductible, that's where you're going to notice it. And again, we just have to balance between cost and effectiveness for you. There's some adjuncts. Daliresp is for chronic bronchitis. This bad side effect is it can cause weight loss, about 20 pounds, and some diarrhea for about the first 3 weeks, but it works really good for the patients that have that chronic cough. Does not work well for emphysema or people that don't have chronic bronchitis. Theophylline is a very old medication. It's about the only medication we had 30 years ago to help control asthma. Has lots of side effects, lots of drug interactions, and there have been some shortages trying to get that medication. Nebulizers, you may have albuterol nebulizer or a ipratropium albuterol, otherwise known as Duoneb. They're meant to play a role in there. Your therapy will be prescribed to you as what works best, but there's always a chance that an inhaler may work better than the nebulizer does, particularly for that maintenance therapy. Oxygen therapy, insurance and Medicare cover oxygen if you typically get a level below 88%. And so a lot of people will come in and say, I think I need oxygen. Doesn't necessarily mean you qualify for oxygen. And there's other social complaints with it about how it looks or how you're going out in public. So you really don't want oxygen until you really need oxygen. But just because you're short of breath does not necessarily mean it's an oxygen issue. Chronic macrolide therapy helps work by an anti-inflammatory. It's an antibiotic, but some people take it Monday, Wednesday, Friday, and just helps reduce flares. And then again, prednisone, which we talked about. And ideally for COPD patients, 40 milligrams for 5 days typically does the best job with the least amount of side effects. Some people may need a little bit more, some people may need a little bit less, but you really want to limit the amount of steroid exposure you're getting. So a COPD action plan, this is what we use in our clinic. Briefly, a green day is a great day. It's your usual day. It's your baseline day. You can do everything that you would normally do. A yellow day might be the weather is changing, a front is coming through, you're coming down with a chest cold, you're noticing more cough, more wheezing. That's when you might be taking more of your albuterol, using a nebulizer, maybe using some over-the-counter, cough medication. If you're in that yellow zone for more than 24, 48 hours, we ask that you call us and we'll talk you through how do we get you better, how do we get you over this, and then theoretically back to the green zone. I usually say red is danger and ambulance, because red for ambulance, and you probably waited a little bit too long. So we really want to try to focus on that yellow zone and keeping you in that green zone, and you're going to fluctuate back and forth between the two. Things to do to help your COPD: quit smoking. It's never too late to quit smoking. Like I said, it's National Smokeout Day. Talk to your provider. There's a Wisconsin Quit line. Talk to Security Health Plan, somebody to help you quit smoking, because it will make a difference in your COPD and your symptom control. Pulmonary rehab, immunizations, get your flu vaccine, your pneumonia vaccine, anything you can do to prevent any sort of infection or illness, because every time you have a flare, you keep losing lung function. So we really want to be preventative and proactive here. Sleep is very important. Stress management is important. As COPD tends to progress, it's not uncommon for people to have anxiety and depression just because the burden of symptoms that they're having. And we also want to make sure people have their advanced directives and do them, and update them frequently so that this disease, it progresses, it's not curable, but it is treatable, that we're doing exactly what you want, that you're going in the direction that you want and we're following your directives. So pop quiz, kind of a just answer to yourself. What's the most effective intervention in the improvement of quality of life in patient with COPD? Is it steroids, pulmonary rehab, inhalers, oxygen? And the correct answer is actually pulmonary rehab. Pulmonary rehab is the only intervention that we have that makes the biggest difference in quality of life. And what that entails is an exercise program at your closest location. Here in Marshfield, we do it twice a week on Tuesdays and Thursdays. And what they do is they rebuild your strength, your endurance, your energy, and they also do education sessions about COPD as well. So again, like we talked about, it increases your blood flow, helps you use the oxygen better, lessens your COPD, increases energy and endurance, improves your cardiovascular health, reduces stress, and improves your self-esteem and strengthens your bones. And if I'm saying, I think you need to go to pulmonary rehab, there's really not much else I can do to kind of help you. You have to want to go to rehab. And it makes a huge difference if you can kind of keep doing that. And I always tell people, it's going to be the thing that helps keep you in your house as independent as long as possible. So those are my references. If anybody has any questions, I'll turn it back over to our moderators.
Thank you, Jackie. So far, we only have one question. So if anyone else has any more, and if Jackie has a few minutes, I do realize we are after our allotted time, but if you do have any questions, put them into the chat. But the one question I have here is pulmonary hypertension the same as COPD?
The answer is no. So pulmonary hypertension is high pressure leading from the heart going out to the lungs. And so you're not able to get the oxygen moving. And there's 5 types of pulmonary hypertension. The one that's most significant is what they call primary pulmonary hypertension. So people have like rheumatoid arthritis or some other connective tissue disease. They may have primary pulmonary hypertension, but it can occur in COPD, but it's not the same as COPD.
Thank you. Did anyone else have any other questions that they want to pop in? Otherwise, I will just thank everyone for joining us today. Thank you, Jackie, for your time and your expertise. We appreciate it. And everyone have a great day and be well.
Great. Thank you.